Good morning, good afternoon, good evening to all of you. My name is Nelly Barrière, and I'm the project manager of the Corporate Partnership Program here at the IAS. It is my pleasure to open this first roundtable in the series, focusing on reaching the 95 targets and how can industry contribute. Despite the progress with HIV testing technologies and uptake, many individuals affected by HIV acquisition do not know their HIV status, and in particular, key populations that face stigma and discrimination. The first event will review current knowledge on key populations and HIV testing barriers to HIV testing and outreach strategies with the aim of identifying areas where industry can contribute to improving the testing for HIV. Just as a quick reminder, here's just a couple of quick housekeeping rules for the roundtable. The roundtable will be recorded, and the recording will be made available to the participants as part of the educational material once we've got all the necessary consents acquired from the speakers. By staying in this meeting, you do consent to being recorded for this portion of the roundtable. We do encourage questions from you, and you can please send them through the Q&A function, which you will see at the bottom of your screen. They can be addressed by the speakers throughout the session and then at the end during the panel discussion. Please remember to focus your questions only on today's roundtable theme, and the questions about the second and the third 95 targets will be addressed during the session on the 4th and the 23rd of May, respectively. We also kindly ask all the participants to stay muted and with your cameras off throughout the duration of the roundtable. However, if you do have a question, do feel free to raise your hand and then we will unmute you as needed. I would also just like to emphasize for all of you that Industry Liaison Forum that is hosting this series aims to provide stakeholders involved in HIV response with a neutral platform to foster dialogue and action along the HIV prevention, diagnosis, and care continuum. We might not find the answers to all the challenges that we will be discussing today, but it is an important step forward in identifying areas where industry can contribute to achieving the 95 targets by 2025. So before we're kicking off this roundtable series, I would like to pass over the microphone to the co-chair of the Industry Liaison Forum, Helen McDowell, for her brief introduction. Thank you, Helen, and it's over to you.
Thanks, Nelly. Good morning, good afternoon, good evening, wherever you're joining us from. My name's Helen McDowell and I head up Government Affairs and Global Public Health at ViiV Healthcare, but I'm here today in my capacity as the industry co-chair of the Industry Liaison Forum. It's a great pleasure to be here, and I'm really looking forward to exploring and discussing with all of you the opportunities and challenges that we have in addressing some of the barriers around HIV testing and outreach for key populations. So joining Nelly and welcoming you all today, and particularly our guest presenters who are shown on the screen or should be very soon. Their names should be up. So we're going to start with a series of presentations and they will be followed by a panel discussion. And in that, we really hope and encourage you to participate as well and post your questions or come off mute and ask your questions so we can discuss what the current barriers are in reaching key populations, but also to share any ideas and suggestions or examples of where you may have done some work to enable and reach key populations that could be, of benefit to others who are here on the call. We do have a packed agenda today, so we do ask all speakers to please not go over your allocated time slots because the discussion at the end is a really important one for everybody. Biographies of all of our speakers should be available in the link, which my colleagues from the IAS will paste in the chat shortly. So with that, I am going to hand over to our first speaker, which is a pre-recording from Cheryl Johnson. She is a technical officer of HIV testing services at the World Health Organization, and she's going to give us a presentation on testing strategies for vulnerable populations, the barriers that they present, and the impact of those. Over to you, Cheryl.
Hi, everyone. Thank you so much for the opportunity to speak with you today about differentiated HIV testing services. And today we're going to focus a little bit about key and vulnerable populations. I'm going to be presenting on behalf of the WHO team, so I've just acknowledged those folks here, but excited to dig into this topic today. So before we kind of talk about where we are and kind of the priorities for key populations, it's, I think, really helpful to look back at how far we've come. And early on in HIV testing programs, very few people with HIV were able to access testing or learn their status. And it was really through decentralized testing with rapid tests, provider-initiated testing, bringing testing into facilities, that we really started to see significant gains. And since then, there's been a strong focus really on additional testing approaches, often differentiated testing, where we talk about self-testing, social network testing, index testing, to really focus our service delivery and reach those who may not have access to existing services. And it's really through these combination of efforts that we're now at a place where about 84% of people with HIV are diagnosed. We're really seeing significant ART scale up. And we've got a lot of options and different services available. So to stay on track, we have to really think about what it's going to take to reach those that we're missing, and also think about learning how to adapt the lessons from scaling up treatment to really being able to scale up prevention access, which is really important for maintaining and achieving that low HIV incidence by 2030. So to do this, WHO guidance really recommends a status neutral approach, one that provides a pathway to prevention as well as to treatment, especially for those with high ongoing risk, such as key populations. So from the case finding perspective, a lot of our guidance focuses on how do we be the most efficient and effective with limited resources, ensuring that as many test kits that we use, we can reach people with HIV who don't know their status. Really balancing the absolute number of diagnoses we can make, say through a facility-based setting, with something maybe targeted through an index testing type approach. And then we also have recommendations around how we do testing to support prevention access, to ensure that people who are HIV negative and at high ongoing risk either stay negative or get the opportunity to start treatment as soon as possible. So here, maybe a classic example might be PMTCT, with incorporating testing at the first ANC site as being a really important prevention strategy. So now, based on that, where are we today? Well, we see that we still have a significant gap of about 15% of people with HIV who are undiagnosed. We see about 1.5 million new infections annually, so we could be doing better. And then when we look at our global data, we really do see that there's populations that we're missing, such as men, key populations, adolescents, sometimes migrants who are coming into country from high-risk situations, opportunities to test people coming for family planning services, partners of people with HIV, STI patients, and also increasingly a group of people who might have learned their status, but were lost to follow-up, either never starting treatment or needing support to re-engage. So when we think about key populations in particular, this is where the vast majority of new infections are coming from. So 70% of today's infections globally are from key populations and their partners, and their risk of acquiring HIV is significantly higher than their peers. So when it comes to differentiated testing services, we have to really think about how we'll tailor our services to reach key populations, really based on their context, the setting. And we really break down differentiated testing services into multiple pillars, mobilizing, making sure we're reaching the right people, the testing service that is really adapted to what the clients and the population want most, and then the linkage that we're not forgetting that it's really the testing program's responsibility that people who are diagnosed with HIV, as well as those at high risk, get that link to treatment and prevention. So what are some of our priority recommendations for key populations? First, sometimes we just jump straight into what's the right testing approach, but actually what is so critical to testing programs for key populations is the right environment, having an enabling environment that really supports quality testing. So we have really our 5 C's that really provide the framework for all testing programs. And one important message is really on U equals U, that this has to be incorporated and is really effective, especially with key population groups that might not have access to that information. We also know quality rapid testing is being really important, whether that's self-testing or lay provider testing. This is really a critical strategy. And so why is this so critical? Well, we do see that if we provide information about U equals U, it will increase testing uptake. We see lay provider testing is often more acceptable and leads to greater uptake among key populations. It's also low cost and affordable, provides a very accurate diagnosis and the opportunity for same-day treatment and also same-day prevention. So today, while there's different assays that can be used for HIV testing, most programs are really opting for rapid tests or self-tests because this is a way that we can really achieve our global goals. And there's really a lot of options out there that are really supporting, the public health impact of testing services more broadly. These products are affordable and really can be scaled up. So these are our two testing strategies that WHO recommends that are primarily rapid testing based, and they can really be useful in a variety of settings. We also have some guidance if those who might be looking for it of how to adapt those testing strategies and develop an algorithm. We do have a verification toolkit to help optimize product selection with the best test kits, which are listed here. There are so many different options available that are low cost, high quality, about 20 pre-qualified HIV rapid tests, 3 pre-qualified HIV syphilis rapid tests, and 6 pre-qualified self-tests. And based on this, the market has really responded to the WHO guidance, and we do see that there is about 36 million test kit growth in the next 5 years, reaching about 206 million by 2027, where we'll see a lot of growth in just the testing market in general. What we're starting to see here in particular is a lot of diversity around rapid test use, so whether that's self-test or the dual HIV syphilis test, which is increasingly going to be important for the market and for countries. Now, despite this growth, we do see that product prices have remained high, and while they're stable, they're unchanged, and this is increasingly putting pressure on programs, making it harder for them to really optimize testing and forcing tough choices. We also see that despite the availability or increased recommendations on self-testing, we're nowhere near meeting the need for self-testing. So despite wide-scale implementation and more guidance around how self-testing can be used, we do really have a significant gap we have to surmount. And this is just a list of those self-test kits that are available. Now we do have a product for about $1, but again, lots of investment and strategy needed to really get this off the ground and implemented. So when it comes to how we then implement our testing services and reach the right people, we do recommend that programs think about virtual interventions and peer-led strategies. So we did a demand creation systematic review that really did highlight these as important tools that can be cost efficient, especially in programs with limited resources. And then when it comes to what to deliver for testing, particularly for key populations, in addition to standard facility and community-based approaches, partner services and self-testing are really critical strategies that can be used in a clinic or out in the community. So partner services for key populations is all about it being implemented on a continuum. It's always voluntary, it can be integrated with other disease areas, and it's important to really adapt to what the client wants or needs. So this could be a service that's anonymous, it could include a self-test, it can be in-person or virtual, and you might have something that's maybe more led by the client or the patient, or something that's really led by the provider. And one of the most effective approaches we've seen for key populations is actually social network strategies. And so this continuum of approaches can really help us, have a comprehensive outreach network, just shown here by some of our colleagues from FHI 360, linking the virtual and then the in-person, the peer-led space, all into kind of one platform that can be really optimized to what the client needs. And for social networking versus kind of our traditional index testing, for key populations, instead of just doing a one-to-one referral of everyone who's diagnosed with HIV, then following up with their partners, we might decide to think about including those who are HIV negative, following multiple waves so that we can tap into a high-risk network that may not, be in touch with the existing health service system. And when it comes to overall effectiveness, index testing, provider-assisted referral remains extremely effective and should definitely be prioritized and offered for key populations. But we see from the evidence as well that key populations can also really benefit from an additional offer of social network testing. And this might be more acceptable, especially in settings where there's very low uptake of index testing. Now, moving to self-care and self-testing, there's really a lot that's happened. And when we think about self-testing, it sits within this broader framework of self-care, which we know is critical to our health system. It can help increase engagement and autonomy, access and equity, quality of care, efficiency, reduce costs to the health system and individuals, and expand our universal health coverage efforts. And this is just a simple framework we developed at WHO with partners that highlights how self-testing can really generate impact, not just in a direct way, but also in indirect ways in terms of health system efficiencies, bringing people back into care, and even having some social and economic benefits. So we've recommended HIV self-testing as a critical approach since 2016. And when we think about key populations, we've got a systematic review that really highlights how substantial the effects are, that it can double positivity when we introduce self-testing because we're reaching some people who either need to test more frequently or who haven't been tested before. And we do find that there might be some needs to really devise linkage strategies for key populations following self-testing, particularly sex workers. Now, we've seen some benefits of home-based ART initiation, provider incentives or peer navigators, but we really do need to ensure that the community is involved with developing those linkage strategies. And then overall, when it comes to the most effective different distribution strategies, online and mail-based distribution of self-tests have performed particularly well for key populations. And now when it comes to key populations, I think we really do need to think about integration. There's so much we want to really work on, and this is just one example coming out of the European region, where there was an initiative to really utilize HIV, STI, and hepatitis efforts to really mobilize testing services more broadly. And we've got a lot of support now with either the dual HIV syphilis tests, different self-testing modalities, to provide key populations with some different options beyond HIV. And there's a lot of support for this now, included even within the Global Fund. So, thinking about some low-hanging fruit, there might be some strategic opportunities to bring HIV testing into STI services. We know there's increased risk of HIV within STI patients, but as we can see from the systematic review we conducted last year, we're often, seeing only 27% of those tested with HIV, people tested for HIV among those with STI symptoms. So a lot more could really be done to integrate services effectively. Now, once we do our testing services, we've got to provide that quality linkage to care and also to prevention. And we've got some, really good recommendations around that. But some simple practices, even just moving to rapid tests, for instance, could be, very impactful. But having friendly or flexible digital tools, peer and community strategies are quite beneficial. And we might also need to be planning on how to incorporate re-engagement. So thinking about, people who are cycling in and out of care, who really need to be factored in, maybe through more mental health support or specific interventions as well. Now, one example I wanted to focus in on today was just about PrEP and how we think about linkage to PrEP or engagement in PrEP following testing. And often, I think from the PrEP perspective, we've historically thought about, the testing is going to happen really regularly every quarter. People are going to stay on PrEP and be negative forever, and there won't be any interruptions if we just keep our services right. But what we really learned is that people's lives and their PrEP journeys are much more complicated. We have people who their risk period changes. They might want to start and stop PrEP at different times. They want to access services when they can or want to, and they're going to miss some visits. So how do we really devise a testing program to support people's real life PrEP needs? And this is what's really led us to more simplified PrEP delivery and the use of HIV self-tests. So what we found in our review leading to our guidelines was that, PrEP could really be beneficial when coupled with self-testing, so that we could have greater effective use, that we could enable more people to start PrEP, as well as to stay on PrEP, and that it was much more acceptable and preferred to many users because of its flexibility. And it was also lower cost than other models. And in terms of, what are the risks of self-testing in PrEP, I think historically, there's been concerns about what if we miss someone who is acutely infected? What if we have drug resistance? And what we found from our modeling analysis is that we didn't have a significant increase in the number of people incorrectly initiated on PrEP, and we didn't see significant drug resistance or significant costs. And overall, as acute infection and overall infections decline, the risk of this just becomes, very small. So really the benefits of introducing self-testing become more and more clear as we move to this next stage of the epidemic. So overall, when it comes to our guidance around how to use self-testing for PrEP, we really see a lot of opportunities to use it as prescribed every 3 months, as needed maybe for those who are maybe irregular or stopping and starting, or as desired in between visits, if it's going to help with effective use. And just one example of a country that did this was Vietnam, when they introduced self-testing and PrEP through a web-based platform. And you can see here during COVID-19, when they first introduced self-testing for PrEP, it really helped maintain their service delivery. And now the country is scaling up to about 22 provinces and more. So I know I've gone through a lot of information very quickly, but I want to leave you with a few quick thoughts. First of all, we have to lay the groundwork for testing program that's going to be successful for key populations. An enabling environment is really critical, and this is going to include lay providers and rapid tests, making sure we have those updated messages, including U=U, and that we're really doing everything we can to optimize the testing algorithms and strategies to support those services. That includes procuring low-cost products. We also have to accelerate the adoption of innovations like self-testing and partner services, and that includes within the use of PrEP. And there's a lot of opportunities for integration in virtual services too that should not be missed. And then lastly, I think as always, there's never a one-size-fits-all. And you can't underscore it enough that key population-led services are really essential, and that ongoing monitoring and engagement with communities will always be needed. So important to factor this in and plan for the strategic mix of differentiated testing approaches. So I just want to thank the team and provide you a few resources as well as some emails. If you have any questions, the team here would be delighted to speak with you more. And I just thank you for the time.
Excellent. Thank you so much, Cheryl, for the presentation. And if anyone's got any questions, please do feel free to send them in the Q&A box that you see at the bottom of your screen, and our colleagues from the WHO will be able to address them. And now I will pass over the microphone to our community representative, Omar, who leads the People Living with HIV Stigma Index team at GNP+, who will provide us with a community perspective on the current barriers to HIV testing. Excellent. Thank you so much, Omar. Over to you.
Thanks, Helen. Good afternoon, good evening, and good morning to everyone who's joining us today. First of all, I would like to thank the Industry Liaison Forum for providing us with opportunity to share our experience in terms of accessing HIV services, in particular on HIV testing. Next slide, please. Just very quickly, GNP Plus is a global network of people living with HIV. We are established in 1992, so it's been quite a while of us engaging in AIDS response at the global level, and we currently operates through our 2 offices in Netherlands, where I'm based, and also we have another office in Cape Town, South Africa, plus several colleagues who works remotely from different regions. Next slide, please. I would like to frame my presentation with 3 major area of barriers. Not trying to simplify the problem, because the barriers can be more than that. But I think it's safe to say that the 3 major issues that I'm going to cover in my presentation is really critical to turn things around in terms of uptake of testing. So the first barrier is on legal environment. I think our colleague from WHO mentioned this several of times in her presentation, that it's really important to create an enabling environment. And part of the enabling environment is a supportive legal environment. Because right now, what we're seeing is we see in a lot of countries still have punitive law, especially for key population, which automatically drives people underground and push them away from health services. The current data shows that numbers of countries do criminalize key population. There are 128 countries still criminalize drug use and possession for personal use, 153 countries criminalizing sex work, more than 70 countries criminalize same-sex practices, some even with a very harsh punishment of death penalty. And we're still seeing a lot of countries, 92 countries criminalizing HIV transmission. And why we put this as the first barrier of accessing services, it's really because the current setup for HIV services relies so much on facility-based, and most of the facility was operated by the government. And this really, create, difficulties or increase the risk of key population to go there and access services because of this criminalization and punitive law that's threatening our way in coming up and trying to seek for services. So this is really a huge issues that has been around for so many years, but we still haven't been able to address it appropriately. Next slide, please. The second major issues is about the program design. As I mentioned earlier, the current setup really relies so much on facility-based services, and most of them are government facility. So this is really, create again a barrier because people really hesitate to go there because there's a very fatal risk if they ended up, encountering problem with law enforcement because they are a criminalized population and so on and so forth. So really, the current program design needs to be improved accordingly with the needs of the target population itself. And this issue is now recognized widely in global AIDS response. In the latest UN political declaration on HIV and AIDS 2 years ago in 2021, all member states agree to reach this target that by 2025, community should be able to deliver 30% of testing and treatment services, and also 80% of HIV prevention services for key population at high risk of HIV infection or key population. So this is a very clear target, and I think it's really comes back to us how we gonna put an effort, a collaborative effort to reach this target. Next slides. So the next two slides, I include this to illustrate how huge is the barriers for community to access treatment because of the current setup. So the data that I'm presenting is collected from the stigma index study, and the data was collected between 2021 and 2022. And I think it's really important to mention this, that this is not try to compare situation in each country, but more like providing snapshots on what's the current situation in this country that is included in this graph. We can't really compare because each country have their own context. So this is, again, just a snapshot. And as we can see, with the current setup, there's huge issues. As you can see in the percentage, the blue bar showing that people were tested without their knowledge. And the orange bar is even worse, even though the number is pretty much small, but it's still happening. And this is about people being forced to go into testing. So this is what we capture from the current setup of testing services. Next slide, please. Another example is, this is related to stigma and discrimination. And again, this is what we're seeing on the current setup, especially in the government facility. There's a huge distrust from the community towards the healthcare workers. And this is mainly because of the trauma of themselves or their own peers, that they going to government facility to access treatment really expose you to risk of being discriminated, of being treated unevenly with other patients. And some of them really actually have that bad experience with healthcare worker. So again, this is showing that the current program design doesn't really work, doesn't really answers to the need or the target that we want to achieve. Next slides, please. The third major issues is about funding. I think in the past 7 to 10 years, we've been working with a flatline funding landscape, meaning the needs is keep on going, but the resources couldn't really keep up to the needs, especially if we're talking on ideal program design for us to really be able to reach 95 by 2030. What really happening is because currently we have two major donors in AIDS Response, namely Global Fund and PEPFAR. And this two funding scheme, I think let's talk quickly about PEPFAR. PEPFAR is basically G2G funding between two governments. So in that sense, government really have control on how they want to use the funding that they receive. And with the flatline funding and the increased needs, what always happen is when it comes to reducing the resource needs, it's very often that the program for a community is being thrown out from the table. Same with Global Fund mechanism, even though it's more engaging in terms of how the funding was utilized. Still, most of the control lies down with the government institution, and often again when it comes to efficiency. Most of the country, take out, outreach program for key population, which really crucial to increase the uptake of HIV testing. So this really, linked to the previous two issues that I said earlier, and I think we came to a point where now how we can use the resource more efficiently, and I would like to use this opportunity to focus on one thing, because based on our experience and our observation, and I think you can also go through AIDS spending from countries. I think UNAIDS have such data that most of the funding for AIDS were spent on commodities. So I think it's really important that this forum thinks on how we can work together to make sure that the spending for commodities is not as high as we spend right now. And to do that, obviously, the industry needs to revisit their pricing policy, their pricing strategies. And this is, I think, in the opening, it was mentioned several times how this forum can contribute. I really do think the biggest way of the contribution from the industry community is really to revisit your pricing strategy. I think that will make a game changer in terms of how the resources will be able to be used on many different important programs. So I'm really hope that this can be part of the recommendation for the forum to again think and address. And I think speaking on behalf of community, especially PLHIV community, we would really looking forward to have this conversation with this forum on drug pricing. So I'm going to end my presentation with that, and thank you so much for the opportunity. Back to you, Helen.
Thanks, Omar. Really helpful and good to see some questions on the table for the discussion later on. So next, we will hear about HIV testing among transgender women that attend the Tangerine Community Health Clinic in Bangkok. So I'm delighted that we are joined by Rina late in the day for you. So thank you for joining us. And Rina is the co-founder of the the Tangerine Community Clinic in Thailand. Over to you.
Yes, thank you very much, Helen, for the kind introduction. And it's my pleasure to be part of this forum. I would like to thank the IAS for giving me the opportunity to speak and share my experience from the Tangerine Clinic in Thailand. So my presentation today will be focusing on how the Tangerine Clinic has implemented different strategies to increase access to HIV testing, PrEP, and other sexual health services among transgender women populations in Bangkok, Thailand. And next slide, please. So in Thailand, it was estimated that there were around more than 300,000 of the transgender women or those who are identified as a transgender feminine spectrum in Thailand. And of those, 62,000 of them, they were sexually active. Of those who were sexually active, around 13,000 of them, they were at high risk of HIV acquisition. And the HIV prevalence among trans women in Thailand was around 17%. Next, please. So in terms of stigma and discrimination in healthcare settings, we conducted a study many years ago, and we found that almost half of the transgender participants in the study, they reported that they never received advice and counseling from healthcare providers on gender-affirming care and hormone use. And almost half of the participants also reported having negative experience from healthcare providers. In addition to that, another study showed the data that around 15% of the healthcare workers, they thought that transgender women who are living with HIV should be ashamed and blamed. So it's really showing that stigma and discrimination against transgender identity and HIV status remains one of the challenges in healthcare settings in Thailand. Next, please. So when I joined working at the Thai Red Cross AIDS Research Center at the Anonymous Clinic in 2015, the Anonymous Clinic is actually one of the largest HIV testing sites in Thailand. And I was asked by Professor Prapan Panupak, he's the former director of the Thai Red Cross AIDS Research Center at that time, that why the Anonymous Clinic did not have any transgender clients to come for HIV testing. And I responded to his question right away that because of the services provided at that time were not unique enough to the specific needs of the transgender populations. And trans population were not thinking about sexual health services or HIV testing only. We have other specific healthcare needs that is still unaddressed by the healthcare providers. So you can see on your right-hand side, this is the list of the sexual health services provided by the anonymous clinic. And many people may have thought that, oh, it's already comprehensive, but for transgender population, it's not enough and it's not adequate to address to the specific needs of the transgender populations. Next, please. So in late 2015, we had an opportunity to establish the Tangerine Clinic, which was located in the Thai Red Cross AIDS Research Center at that time. Through a series of the transgender community consultation, we were able to develop a set of service package catering the needs to the transgender population. So you can see that on your left-hand side, we have integrated gender-affirming care, including counseling on gender transition, hormone prescription, and hormone level monitoring as part of the transgender and gender-sensitive service package offering to transgender populations, and including with the sexual health service package on your right-hand side. And next, please. So, and right now, the Tangerine Clinic was actually established in 2015, and we have come to the 8th year of the service provision and to provide the services for the transgender population, not only in Bangkok, but also outside of Thailand. And you can see in this picture is actually one of the pictures that I'm very proud of, because they are the health transgender people, they are part of the healthcare providers at the Tangerine Clinic. So we can say that the Tangerine Clinic is actually led by a team of the trained transgender people. And they are nurses, they are counselors, and they are also physicians who are understand and gender sensitive enough to provide the services for transgender populations. Next, please. And here are the program data for transgender women. Starting from your left-hand side, now the Tangerine Clinic has provided services to more than 5,000 of the transgender individuals. Of those, 4,800 of them, they are trans women. And you can see that we had observed the high HIV testing uptake among these women, which was 93%. And we found that almost 10% they were tested HIV positive. And we were able to link 90% of them to initiate ART. Most of them, they initiate ART on the same day of the diagnosis. And 97% of them, they were virally suppressed. Among those who tested HIV negative, we were able to link 11% to post-exposure prophylaxis or PEP and 24% to PrEP services. In terms of other sexually transmitted infections, we found almost 30% they were tested positive for either or chlamydia and gonorrhea, and around 10% they were tested syphilis reactive. Next slide, please. In terms of demographic and risk characteristic among transgender women who attended the Tangerine Clinic, the median age of the women was 26 years old. More than half of them, they have below bachelor's degree education level. 24 of them, they were unemployed at baseline. And almost 40%, they had depressive symptoms. 18% reported that they engaged in sex work, and almost 10% reported using amphetamine type stimulants. So it's really showing that by having a transgender-led health clinic is really accessible for the transgender women populations in Thailand. Next slide, please. So you might be wondering how the Tangerine Clinic is able to reach to the transgender communities in the country. So the Tangerine Clinic, we do not have our traditional outreach team, or we don't do the traditional outreach activity, but most of the outreach activity were actually conducted through online, through different social media platforms. So in this slide, you can see that we work closely with different transgender social influencers. We call them as a friends participants of the Tangerine. They represent different background and diverse background of the transgender populations. And we actually invited them to come to use the services at the Tangerine Clinic, and they help spread their word of mouth among their followers and transgender communities, and encourage their followers to come to use the services at the Tangerine Clinic. Next slide, please. So, and now these are the comprehensive list of service package that we have offered at the Tangerine Clinics. You can see that there's something changed on your left-hand side. Right now, the Tangerine Clinic has been able to offer mental health and well-being services in addition to hormones and sexual health services. Right now, our transgender peer counselors are able to provide psychosocial support and mental health intervention to those who have mental health conditions. And we also have a psychiatrist to come to the Tangerine Clinic twice a month to provide treatment and psychiatric medication to those in need. And in addition to that, the Tangerine Clinic also provide minor gender-affirming surgery and also aesthetics services, including Botox and eyelid surgery and rhinoplasty as well. For those who wish to have their genital surgery, we are able to refer them to the Chulalongkorn University, which is a nearby hospital where the Tangerine Clinic have the close collaboration with. So, and in this year, we are planning to integrate viral hepatitis C services as well as harm reduction services, because we found that there are a number of transgender women who reported using amphetamine type stimulant and substance use as well. Next slide, please. And in terms of HIV self-testing, I think this slide actually was presented by Sherry Johnson from WHO already. So, but I just would like to emphasize the role of the HIV self-testing that we have implemented at the Tangerine Clinic less than a year now. And we actually using a status neutral approach to HIV self-testing. For those who screen reactive, we are able to link them to the confirmatory HIV testing. And if they confirm HIV positive, we have to link them to the ART initiation and to make sure that they achieve viral load suppression. And at the below a graphic, you can see that for those who screen non-reactive by HIV self-testing, we would be able to offer PrEP for them as well if we assess their risk already. And next slide, please. And in terms of PrEP initiation and PrEP follow-up by using HIV self-testing, I think this was also presented by Sherry Johnson, but here I would like to show you the service flow for HIV self-testing that we are using at the Tangerine Clinic. For PrEP initiation, all the counseling will be conducted through telehealth platform. And if our clients are eligible, we will be able to post the HIV self-testing kit bundle with the chlamydia and gonorrhea self-collection kit to the client's home. And if our client screen non-reactive, we will be providing post-test counseling through the telehealth platform as well. And if they are ready to get PrEP, the first PrEP bottle will be delivered through the motorbike delivery if our clients living in Bangkok. And our Grab delivery will be able to pick up the samples from the chlamydia and gonorrhea self-collection kit and return the specimen to the Tangerine Clinic. And the result of the chlamydia and gonorrhea testing will be sent to the clients via an application or emails or the telephone. In terms of PrEP follow-up, I think it's quite similar to the PrEP initiation above, but it's less complex. Next slide, please. So this slide shows you the HIV self-testing double cascade at the Tangerine Clinic. Starting on your right-hand side, right now we have distributed around 214 HIV self-testing kit to transgender women clients. And in the middle, the blue bars represented those trans women who return their HIV self-testing result. On your left-hand side, in orange color, we found that 15% they screened reactive by HIV self-testing. And we are able to link almost all of them not to receive confirmatory HIV testing. And we found that around 5% they would tested or confirmed HIV positive, and all of them received ART initiation. On your right-hand side in green bars, you can see that for those who screen non-reactive, we were able to link them into PrEP initiation, PrEP continuation, and PrEP restart. Next slide, please. So I think I would like to share with you some preliminary lessons learned from the HIV self-testing implementation in Thailand. HIV self-testing cascade data are not actually perfect. I think like instead of focusing on how many self-test kits were distributed, how many people reported back their testing result, I think we should be focusing on the national CD4 count at the diagnosis or at the ART initiation, and the continuation rate of the PrEP use from the clients who using HIV self-testing with PrEP telehealth. Second, HIV self-testing is actually the innovative tool to normalize HIV and to empower trans women and other key populations around self-care. And HIV self-testing must be made available in the market and must be included in the national healthcare benefits in order to increase HIV testing coverage and frequency among those populations who in need the most. Next slide, please. And I would like to end my presentation with 3 key takeaway messages. Based on my presentation today, we found that integrated gender-affirming care and trans-competent providers actually increase access to HIV testing, PrEP, and other health services among trans population. People-centered health services must be adopted and organized around the health needs of the people rather than focusing on each diseases. And lastly, transgender-led and transgender-owned programming is key to the HIV community response and should be further sustained. Next slide. I would like to acknowledge all the supports to the funders, stakeholders, and all the community partners for having this work possible. Thank you very much for listening. Thank you.
Excellent. Thank you so much, Rina, for these insights and for providing us with some of the examples from the Tangerine Clinic. And up next, I will ask Duncan Blair to please come to the virtual stage. And Duncan will provide us with the industry perspectives on the challenges of registering the new products. Duncan, over to you.
Great. Thanks, Nelly, Helen, and for all of the organisers for the invitation to participate today. So I don't have any slides today. You know, I could have listed a whole bunch of areas where we register products, but I thought that would be fairly dry. I thought what I'd do instead was sort of talk about some of the broader challenges, issues, and opportunities around getting new innovations or making sure that we have access to innovations for the people who really need them. So, but first of all, I'd say it's been terrific listening to the other speakers, you know, Cheryl's overview of WHO's technical leadership in the HIV self-testing space, I think without which much of what has been achieved today would have been far more challenging to achieve. I think, you know, Omar's remarks were really important to ground us, I think, on what the community experiences look like in attempting to overcome all the barriers faced with really institutionalized stigma and accessing care, and it reinforced for me the role that things like HIV self-testing play in improving access for the people who need it most when you face such institutional barriers. And Kun Rima just rounded out then by grounding the conversation, certainly for me, with a real world example of tailored service delivery. And it's something that I always try and keep in mind when thinking about our work in this space. And I think it's always useful to have that context from different types of tailored service deliveries methods. But so coming back then to the title of today's session and what I was asked to talk about, you know, on how industry can contribute and some of the challenges around the registration of new products. So the industry contribution, I think there are many functions which industry or the private sector can and does play, but really fundamental or the foundational role for industry is really in the development, the manufacture and supply of healthcare products. certainly in the case of the type of industry that I represent. There are other roles which industry can play as well to a greater or lesser extent in different circumstances, which may include community education, healthcare provider education, informed policy debates and advocacy, contributions to basic science, be it behavioural, biological, epidemiological, and so on. But at the end of the day, I think what we're talking about here, or what I want to discuss, is the delivery of critical healthcare products, which is fundamentally what we're about as an innovation company, and as a sector in general as well. So, one important aspect of industry's role in delivering health products is, as I mentioned already, innovation. But I think I'll come back to the concept of innovation in health products at the end, because first, I think it is worth talking about how we, as manufacturers, do get health products such as HIV self-test into the hands of people who need them, whether it's lay providers, individuals doing the test themselves, actually achieving the task of getting these to market where they need to be. And so for the purpose of today's discussion, that really starts with a bit of a discourse on regulation of healthcare products. So across all types of healthcare products where a clinical decision or an intervention is potentially being made, including HIV self-testing, I think it's pretty easy for us all to agree that there is a need for regulation. We need to regulate what's available in the market with such critical interventions being made. Now, regulation itself, or regulatory regimes, are designed around ensuring that products actually do what manufacturers claim, that they reliably meet the intended specifications, and are manufactured and provided with consistent and assured quality. So again, just doing what they say on the box and doing it reliably and doing it safely. At its core, regulatory processes are based around a very clear, documented set of established rules and specifications. And these are followed by regulators and manufacturers alike to ensure that the products do indeed meet those standards and that suppliers are being compliant with all necessary relevant processes. Now, conceptually, that seems simple enough, but the actual execution of health product regulation is a very complex business, a very complex process. Typically involves specific legislation domestically across whichever jurisdiction we're talking about, or all jurisdictions, and requiring a significant amount of expertise and resources to establish systems, implement systems, maintain systems, and continually improve those systems. So fundamentally, governments need to invest in human resource capacity, technical capacity, infrastructure, bureaucracy, and so on and so forth. And I think a major challenge in the global public health field, where many, or indeed most of us work, arises when there is a need for regulatory oversight for health products, but domestic capacity may be lacking, or the domestic capacity to deliver that oversight might be lacking. So specifically, the lack of domestic capacity for a fully fledged regulatory system is actually pretty common in low-income countries. A lot of investments and great strides have been made in improving that capacity in recent years. But in many cases, having a fully functional regulator, certainly in the diagnostic space, it's a little bit different in different sectors. In diagnostics is really the exception rather than the norm. So, in the absence of clear regulatory requirements and regulatory systems on a country-by-country basis, for a company, the process of delivering a health product for use in many countries then is quite ill-defined. The process can be opaque, it can be costly, it can be time-consuming, and it can be highly variable. And these are all things that make life difficult for a company when they are sort of trying to introduce products into market, really to ultimately serve the purpose that we all want to serve. Now, usually, even when there's a lack of a strong regulator, usually some form of product registration is required. But then what constitutes registration can vary wildly from one jurisdiction to another. So registration may be as simple as the submission of a limited amount of documentation and paying associated licensing fees or associated fees just to enable import and distribution of a registered product. At the other end of the spectrum, it may involve the need for really extensive laboratory, clinical, and end user evaluations to be undertaken domestically on domestic samples with domestic populations. Excuse me. Now, just on the single country level, that can be really challenging for a company where, again, the requirements for study design and execution may not be well established or even defined at all. And then we might have some small countries that we need to deal with where simply statistically speaking, achieving the statistical significance and power of studies can be a real challenge. So that's just on the single country level. However, the real challenge becomes apparent when we look at registering product across many countries, which of course is something we absolutely need to do. We need equity of access, and that means borders should not ideally be relevant. But in going to many countries, in doing that, the challenges that we face are then multiplied by the number of countries. At least multiplied by the number of countries, and as are the associated investments which are needed. And those investments are investments in time, financial investments, and also investment in opportunity costs, time and effort and money that could be spent doing other things in other places for different kinds of returns, whether those returns are public health returns, individual health returns, or financial returns. All of these are important in the way we all run our work and our business. So the uncertainty associated with individual outcomes in countries, and really the need for duplicate efforts across different countries, really doing the same work in multiple countries, does present a significant challenge and risk and barrier for developers and suppliers of health products, including HIV self-test, but really across the board. And this is where we come to an important function which is played, at least somewhat, by the WHO in the pre-qualification of the diagnostics. Now, while not a regulator at all, it is fair to say, I think, that the pre-qualification of diagnostic system is widely accepted as a de facto standard setter, if you will. It's kind of a keeper of quality within the market. So it keeps everybody to the same standards. It's the same status quo. Now, on a level, this is a really good thing. It ticks many of the boxes around ensuring that we have quality, the quality and the safety which are needed, which we discussed earlier. There's a flip side, however, which is that with WHO not being a sovereign statutory authority, rather it's a member organisation which is providing guidance and advice to its member states. It's not a regulator. So achieving pre-qualification does not achieve registration or uptake. I would just say, as an aside, in addition, while I think PQ is very, very important, it itself is not without its own challenges, including some challenges around timelines and predictability, which I know are functions of their own limited resources. But that's a longer conversation. I would just say that, in short, some attention on PQ reform, I think, is still needed, but I don't want to go into that in detail now. I would say that, in effect, PQ does provide, pre-qualification of diagnostics does provide a respected and trusted standard of quality for implementing countries, associated partners and procurers and financing agencies, to enable them to have a high degree of confidence in the validity and the quality and safety of any given product. However, meeting the PQ standard, as I just mentioned, is rarely, if ever, a sufficient bar to enable local registration and procurement. Or to put it the same thing a different way, PQ is often or even usually required for purchase and importation, but it is rarely, if ever, sufficient for that purpose. So I mention that because effectively what we end up is two layers, if you will, of regulation in which become necessary to gain market access. So there's that of PQ itself, which is this sort of pseudo-regulatory quality standard, which is set very high and in itself a good quality system, plus whatever is needed locally. So we have dual processes which are required rather than a single process, which you may need to follow in any other country that does have a fully fledged regulatory system unto itself. So just circling quickly back then to the individual country registrations and registration and regulation, if you will. Many efforts have been made to address the duplication which is inherent in repeated local evaluations of diagnostic products. And most of these have achieved to have aimed rather to achieve some level of regulatory harmonization, whereby approval in one participating jurisdiction leads to an automatic or at least expedited in approval in another participating jurisdiction. So a little bit like the European Union in a sense. And this has been, efforts have been applied across sub-Saharan Africa and Southeast Asia and LATAM as well. But these efforts, they make a lot of sense, but for a whole variety of reasons have not really proven to be terribly effective to date. And people have been working on such programs for, I'd say, at least a decade, perhaps even closer to 2 decades in some cases. So I think more effort in that space on moving towards a harmonization is still needed. But given the limited progress, I think there is at the moment a lot of discussion around shifting towards a concept of regulatory reliance rather than harmonization, where reliance, it still captures the idea of sharing the workload and burden of specific regulatory functions, which is, again, requires a lot of investment on a country national basis between jurisdictions, but then maintaining the ultimate regulatory decision within the sovereign capacity of the individual states. So a little bit of a hybrid between what we have today and I guess the European model. Now, overall, I think there are a lot of ways to achieve the goal of simplifying regulation and to enable greater and faster access to healthcare products, including HIV testing products. But it really is important, I think, that whatever systems are ultimately developed and adopted don't represent additional layers of regulation which add no value, but add complexity. So duplication upon duplication, I think we need to really avoid. So just before wrapping up then, coming back to innovation, which I mentioned at the beginning, I think we often see, and by we I mean collectively all of us in the public health space, that there are gaps in the suitability of specific interventions or specific health products for certain situations, right? So, HIV rapid tests in general are great for a whole bunch of things, but they're not perfect for all situations, as we learned from Omar and also from Rima. There are different situations where you need a different delivery model. So HIV self-tests are a great example of taking an underlying technology, modifying it, innovating it, so that it provides better access for most at-risk populations. And that's been a great innovation. There are many others as well, but product innovation, I think, is a large part of what we do in industry. But it does require investment. And for investment to happen, there needs to be an assessment of risk internally. And companies are generally happy to develop new products with some level of risk associated with that development. But the better the understanding of the risk, then the greater the appetite for the investment. So ultimately, the potential better return in terms of delivering better innovations, which will ultimately provide better services for most at-risk populations or populations in general. Where risk is hard to assess, it can be harder to justify investment. So these complicated and opaque and unpredictable regulatory processes really do present a significant challenge, and it's a bit of an unfortunate feedback loop that we end up in there. So, in conclusion, I think what we would like to see and work towards with, all interested parties is an avoidance of unnecessary duplication of regulatory effort, which really adds nothing to the quality of a healthcare product or healthcare delivery, which does have the effect of slowing access and reducing the overall number of individuals who can gain access, because it pushes up costs and it inflates timelines, which simply isn't necessary and isn't necessary based on science. And I guess furthermore, these problems or these challenges can really disincentivize an investment in further innovation. So, in closing, I think we all support a really strong, effective and efficient regulatory system. Whatever form those regulatory systems may take, be they domestic, regional, international. But as a takeaway, I want to emphasize that, efficiency is what we're after, never compromising on quality, but always striving for efficiency so that we can expedite access and expand access as much as possible to everybody who needs it. And with that, I'll end here. Just thank the organisers once again for the opportunity and look forward to further discussion. And I think I'm throwing back to Helen, or is it Nelly? I'm not sure.
It's to me. Thanks, Duncan. Some really important and pieces there, I think, that can be picked up in the discussion. So we have got about 15 minutes now for discussion, with the meeting due to close at 1/2 the hour. So I'm very pleased to ask our panelists to come off mute, and if you can, and your bandwidth allows it, please do put your camera on. So very excited that we have Antons, who is the Technical Officer for Key Populations at the WHO, Global HIV, Hepatitis and STI Programme Team. We have Jennifer Sherwood, who is Public Policy Manager at AMFAR. We have Tafadzwa, is the Zimbabwe Country Director of ICAP at the Columbia University. Then we have Samuel, who is from Beckman Coulter Life Sciences. He's Director of Alliance Development and is another member of the ILF. And finally, I would like to warm welcome to Ombeni as well, who is at UNAIDS as a monitoring and evaluation manager. So I think we, through the discussions so far today, we've seen some very clear examples of guidance and evidence to support those that were demonstrated by the WHO in terms of testing and particularly self-testing. I think we've seen a really compelling example of community-centered care really helping to bridge the gap and make sure that communities in those key populations, some tried and tested ways to actually reach those key populations where we know are the biggest gaps. Then I think we've also heard from Omar some of the challenges, probably on a broader community level, about testing, and then that next step to linkage that we will pick up more in the second round table. And then finally from Duncan, I think really important pieces around the technology behind the testing and the processes that are there to support and make sure there is quality, but actually some of the processes do also hinder speed and incentivization to make these testing innovations available as broadly as I think we would all like to see. So picking up on those pieces, it would be great to get into a bit of a discussion, and let's start with about the impact of diversifying testing strategies and how we deliver tests. What impact have we seen in other programs around the world? I'm going to ask Ombeni to comment on that, and then Jennifer as a starting point.
Thank you, Ellen, and thanks to all the previous speakers whose presentation have shed light on this question, on what we know about the benefits of diversifying delivery approaches. I think I can say upfront that I would like to say thank you to the HIV response community. There is a great deal of information and evidence and best practices that programs in settings of slow progress can already tap on. We know, for example, that the delivery approach should take into consideration the end user uptake dynamics, understanding what their preferences are and propose solutions that work around their barriers. We know that consumers are not all the same, and delivery approach should be diverse to meet their respective needs. We also know that what works in one country may not be what works in another country. So diversifying delivery approach require country and context specific approaches. We also have heard, and this also came up from Cheryl's presentation, the fact that we need to have comprehensive options, options that spans across facility and community approaches, private and public sector approaches, options that adopt public and private partnership models. There are also many advantages in integrating HIV testing services with other services, for example, in HCV, HBV, in TB and STIs settings, but also in pediatric clinics, which is an area where we know they are under testing. But also decentralizing outside the health systems have also been proven to show increased in testing uptake. We also have heard that task sharing, including by lay providers in the communities, and task shifting to pharmacies have also shown to benefits. In key populations, Services needs to be simplified, easy to access, provide privacy and confidentiality at times that are convenient to them. We've seen some examples, for example, moonlight testing in Kenya, where has increased uptake of testing among female sex workers. We also know integrating with other health and social services in one-stop shops or in drop-in centers at community levels and venues that key population use have also been very beneficial. Some examples that we have seen in projects that UNAIDS have invested in to reach hidden key population, for example, peer-led testing approaches and social networkings have reached clients that we would never have reached if self-test would not have been offered through this peer-led organization. So there is a great deal of information that already exists, and in many settings, we do not need to reinvent the wheel. I think what would be essential is to make sure that these are adapted into country and local context.
Brilliant. Thanks, Ombeni. I think some really clear points then. Jennifer, can I ask you to add to that from your lens?
Great. Yeah. Thanks, Helen. Thanks. I think much of, I want to echo many of the other speakers just to say, of course, that not every strategy and every technology works for every person. And so, of course, as we diversify approaches, we increase client choice, we can increase uptake of services. I think the one thing that I would want to unpack and continue to add is around the importance of friendliness of services and the importance of making sure that as we drive people towards services, that when they arrive at that service, that service is friendly and safe. And that is a really important aspect of this. And I would say AMFAR is involved in quite a few community-led monitoring projects around the world. And I think that CLM data is an incredibly useful body of data that we can look to help examine the factors that are contributing to different client preference and choice. From one of our projects that we're working with in South Africa, the Rachitse community-led monitoring project, which has one of the largest KP CLM data efforts that I know of anywhere in the world. They reach around 9,000 key populations last year. And some of the primary goals of this data is to look at service gaps, preferences at various sites. And I think they found many things, but some of the top lines that they found was that overall satisfaction and acceptability of services and HIV testing were much higher at drop-in centers and at mobile clinics than at public health facilities, but that around 70% of the KPs that they surveyed were not aware of a drop-in center or mobile clinic near them. And so I think that this puts us in a specific conundrum, which is that we want to make sure that we are continuing to invest and expand community-based testing services like drop-in centers that are safe and friendly for key populations, but that the majority of KPs in South Africa and perhaps other settings are still using public health clinics. And so additionally, we need to make sure that when people attend public health services, that those are safe and friendly. And so there's sort of a dual track that needs to happen. One other important piece of information that came out of the CLM project was that there was a high level of service denial at public health facilities. 19% of people who inject drugs said that they were denied service at a facility, 12% of sex workers, 10% of trans people, and 6% of gay, bisexual, and other men who have sex with men. And so I think that additionally, when we're thinking about how to reach people with services and how to drive people to services, we really need to also think about whether or not those services are accepting and friendly once we get there. Because if the services aren't safe and they're not friendly, no matter what we're offering, people will not be accessing them. Thank you.
Great, thanks, Jennifer. I think there's a very strong theme in here about the criticality and importance of not reinventing the wheel, but also the importance of community really being the critical point for, you know, bridging that gap to the key populations that aren't being reached. Can I ask, obviously pulling on the fact that this is the Industry Liaison Forum, if I could ask Antons and Tony to maybe reflect a little bit on what is the role of industry in this and in enabling and driving more demand and supporting communities. What are your views on that? So maybe Antons, if you want to sort of speak first, and then Tony.
Well, I think the role of the industry is developing the new products which are more user-friendly, also to make sure that these projects are registered as we heard in a previous presentation. That could be one of the biggest challenges, apart from the pre-qualification, but there is also the need for product registration. I think the industry might have some role in supporting some demonstration projects or providing funding for community-based organizations to develop different projects which aim at demand generation. So we have a lot of good examples. Yeah, I think that's definitely the role, and also diversify the different products. So, for example, tests. Some people prefer blood-based HIV tests. Some people prefer saliva-based HIV tests. So the more diversifying, not only the services but also testing modalities will increase the uptake of HIV testing, and also using the dual tests. Now we recommend dual HIV syphilis test in antenatal care, but now also for key populations. This recommendation is going to be developed soon, but there also probably dual tests for HIV and hepatitis and other infections. So I think there's definitely a role for the industry. Over.
Thanks, Antons. Tony, can I ask you to make a comment on this as well, as a fellow industry member?
Absolutely. First of all, thank you for having me today. And just so there's no confusion, my label is Samuel Buva, but I go by my middle name, Tony, so apologize for any confusion there. I represent our medical and scientific affairs organization and also our global market access for Beckman Coulter Life Sciences. We're a Danaher company. As an industry partner and manufacturer, in my role, we are supporting education, training, advocacy, and we are primarily supporting HIV testing. Now, one of the things that became clear to us is that to reach some of the unaccessed populations, such as key populations that have already been mentioned, there needs to be more involvement from civil society. And I think that there's a role that industry can play to achieve that goal. And one of the things that we have done in the past, which was very effective, was that we looked for ways to really understand who the community organizations were that really have influence within these key populations. So one of the things that we did as a manufacturer, and this may seem a little unorthodox as a manufacturer, but one of the things that we did was we launched a community recognition award to be able to find individuals who are really doing volunteer work at their communities, but they're also doing very important work because they're addressing key populations. And it enabled us to find small organizations, some of whom were registered charities, some of whom were not. One organization was involved in supporting youth who were positive for HIV. And they had a tremendous amount of influence in these communities. We also worked with another organization, which was a registered charity, and they also were involved in supporting key populations. And I think this is a foundational opportunity for manufacturers, industry partners to get more involved and then look to take that to the next step and say, how can we leverage those organizations to be able to create more of a friendly environment that Jennifer talked about? And I totally agree with what you said, Jennifer. People have to feel safe to be able to approach these services. And I think some of these community groups have the opportunity, they're trusted in these communities, and they have an opportunity to create that safe environment. And another example of what we've done as an industry partner is we have worked to drive more demand in one country in particular to help them look for ways to be more efficient, to go out as close to the patient as possible. But this is more around specimen collection and then transferring it into a national referral laboratory. But I think that's the other aspect of this is that there still needs to be a national footprint where there needs to be more testing modalities available and more services available at national level. Centralized testing continues to be a bedrock of laboratory testing. So I think I'll stop there. The only other comment I'd like to make is I think I also agree with Duncan in that as a manufacturer, we need to look for ways to streamline new product registrations, and then there's the uptake on top of that. So there's a lot of challenges bringing product to market. It represents a significant investment, and there's lots of duplications of regulatory compliance that have to be met. So if there's a way to harmonize, I think that would go a long way to addressing better access or quicker access.
Thank you, Tony. I think I'm going just to take over for a couple of questions. And my first question would be for Fadzwa. I think we heard a lot about the importance of having diverse tools and diverse approaches for doing the testing. And in particular that self-testing was one of the recommended or preferred method for the WHO. We also heard from Rena that it was acceptable. Could you tell us a bit more what we know about the motivator for people to take a self-test and what could be the obstacle at the same time also? Thank you.
Thank you, Roger, for that question. I think to properly respond to it, we should quickly summarize the earlier discussion that Oma and others have brought to the fore about the barriers to HIV testing among key populations. I think as highlighted by previous speakers, these are at multiple levels. We have stigma and fear of discrimination, discouraging people from seeking an HIV test. We also have the threat of harassment and violence, compounded by the prospect of arrest in countries that criminalize KPs. And even for those that access health services, the quality of services offered is often compromised by judgmental attitudes among health providers. So these and other social and legal barriers lead to the low uptake of HIV testing services among KP. Therefore, HIV self-testing presents as an attractive method to KPs as it offers an opportunity to personalize or individualize the HIV testing experience. Unlike the conventional facility-based testing, self-testing can be carried out privately and conveniently at the user's discretion. So it is well suited for key populations who may be facing the barriers described before. For key populations in countries that ICAP is doing work in KPs, we found that for key populations such as gay men, men who have sex with men, the transgender community, self-test kits have been ordered online. They've managed to order them over social media and have them delivered to their homes, and that has proved to be quite useful. In other countries, we see community centers and peer support groups now providing HIV self-tests, and in some cases, self-tests are even available in vending machines. So to sum it up, the motivators would be privacy, convenience, pain-free testing, and ease of use. And I think those are the motivators that we can leverage to scale up testing among KPs using HIV self-testing. Over.
Thank you very much, Tafadzwai. I had a follow-up question, but I think, Helen, you have to go, right? Or would we?
Yeah, I think we are. I mean, we're due to finish in 1 minute,
Okay.
and I do have a hard stop for another meeting. So I think clearly we probably could have gone on quite a lot longer with questions, and I am aware that there have been 1 or 2 questions come in through the chat. So thank you to those of you who've posted them there. We will note those questions and make sure that they are included as always in the summary note that will come from this roundtable discussion, and make sure that if you have any other thoughts after this, please do share them. I think Julieta from the IAS team has put the email address in the chat, so do please share any other comments, questions, thoughts from today's discussion, and that will be part of the compilation of the full roundtable series for the ILF. Thank you to all of the presenters today and the panelists. I think there's some really rich examples and a huge variety of topics that we've covered, from regulatory through policy through legal and criminalization issues. The fundamental takeaway to me is we need to do more that is community led, and that is going to be absolutely critical to reach that 95% particularly in key populations. I'll close by saying a big thank you also to the IAS team, and a reminder that the next meeting in the series is on Thursday the 4th of May at 3 p.m. UK time, 4 p.m. CET. I won't try and do any other more time zones for fear of getting it wrong. The second roundtable in the series is on the second 95, which is about linkage and retention in care. And what we intend to do there is obviously a short review on the existing strategies, but then to focus in more on what do we collectively need to do, and what is the role of industry in driving the reduction in that gap of that second 95% of people knowing their status and being linked to care and on treatment. So I look forward to seeing you all again at the second roundtable on the 4th of May. And thank you very much for all of your inputs today.
Thank you, everyone. Bye.
Thank you.
Thank you.
All right, thank you, everyone. Bye.